Okay, good afternoon, everyone. There's still some people joining, but in the interest of time, I think I'll make a start now. So good afternoon, everybody, and welcome to today's BHF Data Science Centre's monthly webinar. And many thanks to all of you for making the time to attend. My name is Reuven Preden. I'm one of the Centre's research project managers with a focus on managing the CVD COVID UK COVID Impact Research Programme within our structured data thematic area, and I'll be chairing today's webinar. This month's webinar features key updates from two rapid research projects, which were announced at the start of this year. The projects were launched by Health Data Research UK and funded by the National Institute for Health and Care Research, with the aim of trying to ease winter pressures on the NHS. Today, we're delighted to welcome Dr. Honghan Wu, an Associate Professor at the Institute of Health Informatics at University College London. Honghan will be joined by Jinga Wu, a PhD student also from the Institute of Health Informatics, who worked with Honghan on a project entitled Using Machine Learning and Rare Disease Phenotype Models to Identify People at Risk of COVID-19 Related Adverse Outcomes. Our second presentation today comes from Professor Nazrul Islam, Associate Professor of Epidemiology and Medical Statistics at the University of Southampton. Nazrul will discuss a project which he co-leads with Dr. Danber Miller entitled Using Data Science to Better Characterize Multiple Long-Term Health Conditions. Before I hand over to our first speaker, may I please ask everyone to kindly keep their camera and microphone switched off, and to make you aware that this webinar is being recorded. And it will be made available along with recordings from our previous webinars on the BHF Data Science Centre's playlist on the HDR UK YouTube channel. There'll be time at the end of today's talk for discussion, so please post your questions in the chat, and we'll do our best to answer as many of the questions posted as time allows. Finally, if you would like to present at a future webinar, do let us know in the chat, and Kate McAllister, our communications manager, will follow up with you. So without any further ado, I'll now hand over to Honghan and Jinga.
Thanks, Ruben. I'm going to share my screen. Let me share this one. Okay, yeah, as Ruben introduced nicely, so this first talk we did it by myself. My name is Honghan Wu, and Jinga Wu, who is a PhD student in my group. So our project looked at rare disease patients of their risk in terms of catching COVID, what kind of adverse outcomes, risks like mortality particularly. So there are challenges really in identifying these high-risk patient groups, including how can we identify those patients at scale in the whole, for example, English population who are rare disease patients. And second challenge will be, we know for rare disease patients, they are just like any diseases, they are likely to be underdiagnosed or later diagnosed. For rare disease, even worse because of the situation, like they are very rare. Not every doctors or not all the healthcare services do this screening, do this diagnosis on time. There's technical challenges and the clinical challenges of that. So the work basically naturally forms two parts. One is identify those who we know they're rare disease patients based on our healthcare system, like the structured data in our populational and healthcare database. The second part is about how can we identify those who we don't know they are rare disease patients, but they share similar vulnerability, like those who coded as rare disease patients. So the first part we did by myself. The second part we will introduced by Jinga. Okay. So the first part we use the COVID UK English population data set, which is linked health data set, including about 58 million people's health data in our trusted research environment. managed by BHF Data Science Centre. So the first step is we start with all the rare diseases as defined by a community effort called orphanet. For those who don't know this orphanet, which essentially is a community from international collaboration trying to identify, define all the rare diseases. So in total, there are more than 10,000 recorded rare disease entities. Majority of them are diseases, but some subset are groups of diseases. So we start with all the orphanet entities which define the rare diseases, trying to identify those rare disease which have very good coded data in our English population. So you can see this this kind of flow chart, how we start with the 10,000, end up with 331. There are 7 steps at the right-hand side of this flow chart. We exclude a lot. Majority part of that reason we exclude them because we don't really have very good, or either they are not rare disease per se, there could be groups of rare diseases, or that we don't have very good coded data in our UK healthcare system, or we don't really code those patients or those diseases now in our healthcare system. Like this box here, if you can see my mouse, it's about 3,400. We'll exclude it because we don't really have, for example, ICD-10, which is the international standard for diseases. We don't really have those codes for rare disease in the current ICD-10 codes now. Okay, essentially, this slide tells us out of 10,000 often the entities, we end up with 331 rare disease, which we are confident we have good quality coded data in our data set. So the rest part of this first section of our presentation focus on the 331 diseases. The first step, what we did is try comparing what is already known in the literature, mainly collated by orphanet. The figure you can see here, the x-axis basically is the 1, 2, 3, 4, 5, 4 different strata of rare disease prevalence reported in the literature, like those less than 1 in 1 million population to 1 to 10, 1 to 9, or 10 to 99, or 100 above. And as you can see, the y-axis is what we observed, we analyzed it using 58 million English population data. The gray box basically sets the region where our analysis is in line with the orphanet collated literature prevalence for these diseases. Each dot here is a disease. Those orange ones are those exemplars we identified as for detailed discussion in our manuscript for each different strata. As you can see, there are some good overlaps in each strata, but we do have some kind of new evidence, let's say, using the real-world data for the prevalence for all these rare diseases. And the right-hand side column, which is about 186 diseases, all of these we don't really have, we don't have the prevalence data in the literature, but we're using our 58 million people data. We can report first time about their prevalence in the English population. So which means that using real world data, actually we know we can derive much more detailed and hopefully accurate, to our confidence more accurate compared to most of the studies reported in literature to this day. Okay, and then we set out to do the analysis for those 331 diseases, for their survival analysis, for their risks of mortality if these people caught COVID-19. As you can see, the top left column, the top left corner, which is a wave 2 not fully vaccinated exemplar disease called progressive supranuclear palsy, which is a neurological condition that causes problems like with balance, movement, vision, and speech, swollen. As you can see, this red bar, red line is for those patients which coded as rare disease patient of this particular disease. Those blue bar is that for control, matched control cohort, which match based on gender, age, ethnicity. So as you can see, there's much higher for this particular disease if people haven't been fully vaccinated for their mortality. The top is about 60 on the y-axis. The top right corner is for wave 2 fully vaccinated. We have exemplar disease called bolus pemphigoid. Sorry for my pronunciation for the particular disease. I'm not so good at these disease names. So this is a rare skin condition that mainly affects older people. As you can see, there's about 20 is the number here, much higher compared to their matched control. And the bottom two diseases, the bottom two are groups of diseases. As you see, you group renal diseases together. You can see for the renal rare diseases, as a group, they actually have much more higher. If not vaccinated, about 12. That's the number. Even for vaccinated, if we look at infertility disorders, it's about 4 as a maximum reading on the y-axis. So essentially, this slide tells us for particular rare disease patients, they have much higher risks of mortality if they call rare disease. We just show you these exemplars, both at disease level and groups of disease level. And out of 331, this slide lists all the 28 rare diseases. We find those patients have significantly higher risk of COVID-related death. And I'm not reading all of these diseases, but essentially just summarize, out of these 28 high-risk diseases, 27 of them are not in our government sharing list in the pandemic policy, public health policy at that time. And even you look at individual level, you might think, for example, if people have the disease is not included, but the individual might be included in the high risk shielding list for some other reasons, like old people. But if you look at individual level, 7 diseases were underprotected based on the public health policy during the pandemic. Out of the 28, I just highlight only 1 disease was included in the public health policy for the pandemic management during that time, which means we might have missed a lot of these high risk patients in our shielding list during the pandemic. And this slide basically breaks down a bit more, look at mortality hazard ratio, put into the median age of the first diagnosis of this disease and prevalence. The x-axis is the median age of the first diagnosis. The y-axis is the adjusted point prevalence per million for these diseases. The dots, each dot is a disease or disease groups. Different colors means different things. Like the red means those high risk. The hazard ratio is estimated based on disease, vaccinated disease patients. And the orange one stands for these unvaccinated patients, and light red stands for those disease categories. And the size of the dots basically shows the hazard ratio, the actual value. As you can see, for this one, for example, if you can see my mouse, there's a very young age but very high risk of mortality. They caught COVID. And this disease actually is quite high in terms of this prevalence in our English population. So this gives us an overall kind of visualization of these patients in terms of their risks if they caught COVID in terms of mortality. Yeah, that's the first part. I may hand over to Jinge for the second part. Jingle, I can keep sharing the slide. Maybe you can just talking. I move the slides over. Is okay?
Okay. Thanks, Honghan. So previously, Honghan has introduced that there are 28 rare diseases with significantly high increased risk during the pandemic. And furthermore, some of the patients are undercoded, which means that some of the patients which are not coded by rare disease, but sometimes they share some similar vulnerability with the coded patient. So this the second study aims to use some techniques to identify these maybe overlooked high-risk people. So next slide, please. So the process is like this. So for each disease of those 28 rare disease, high-risk rare diseases, we curate the rare disease phenotype models from the two resources called Genomics England and orphanet. They are in general have a good definition of the disease phenotypes. So for each disease, we find the phenotypes from these two resources, and we have a mapping from the phenotypes to their ICD and SNOMED codes to find cohorts in the national data set. And then we use the phenotypes to train a machine learning model for a binary classification. So for each patient, we use the model to identify whether this patient is a rare disease patient or not. And then we use the machine learning model to identify all the false positive with high probability, which means that the model think this patient may have some similar features with the coded people, but they are in reality not coded. And we then do a risk analysis of the false positive cohort and the control cohort. So next slide, please. Thanks. So this is in general first in general the results of the machine learning models. So a summary for the phenotype model and the machine learning model is that we can find the phenotypes of 22 rare diseases out of 28 in total, which have over 1,650 phenotypes in total, and nearly 500 phenotypes can be mapped to either a ICD code or SNOMED, and almost 200 phenotypes we can find the coded data in the national data set. And we use these phenotypes to combine the phenotype and the demographic features such as the age, gender, ethnicity to train the machine learning algorithm. So for the machine learning model, we choose logistic regression, random forest, and XGBoost. And here are the ROC AUC score. And of all the 22 diseases, 10 rare diseases with a relatively higher accuracy with ROC AUC over 65%. So in the next slides, we are going to have a risk analysis on these 10 rare diseases with a higher accuracy. So very similar to the results from Honghan. This is a control cohort versus false positive with high probability predicted by machine learning algorithms. So the red line means that this kind of patients is not coded, but the model thinks they are kind of in high risk with the case cohort. And the blue line means the model thinks this kind of patients are not in high risk in general. So you can see in these 10 diseases, the pattern is quite clear. Almost all these 10 diseases, they have a very significant difference during these two cohorts, which means that in general, our model can help predict some people which are not coded but in high risk. And for the next slide, this is the wave 2 result during the pandemic. So very similar to wave 1, the model in general can also identify a lot of number of patients with higher risks but not coded. So for the next slide, we have a further comparison of the shielded patients. And the first column is the shielded patient, the coverage of shielded patients in the control cohort, which is not considered as a high-risk patient from our machine learning models. And the second column is the coverage of shielded patients in the high false positives, which is also very previous to, which is also very clear to see that in general, the model predicted a lot of a good number of vulnerable patients, which are not coded in the current data set. And next slide, please. So in summary of the two work, the first thing is that we might have missed the opportunity to protect some rare disease patients during the pandemic. And also the national data set, which can provide us the good resources for better managing the rare disease patients. And then our machine learning algorithm plus the phenotypes model can actually work to help identify a lot of people sharing the similar vulnerability but are not coded with the current data set. And also the project is more or less still in progress, and we do have a future plan to improve our machine learning predictions in the future research. For example, for some of the model may not have a good accuracy. For now, we have a plan to do a actual feature selection from the data-driven approach. For example, inside our national data set, we're going to take a deeper look at those codes and trying to select some clinically meaningful subset combined with the current phenotypes. And we will use the more features to help have a better prediction and help to identify more patients with potential high risk. And that's it.
Many thanks, Hong-Han and Jinga, for that presentation. In the interest of time, I'm going to hand straight over to our second speaker today, Nazul Islam. But please remember to post any questions that you have for Hong-Han, Jinga, and Nazul in the chat, and we'll hopefully have some time afterwards to put the questions to them.
All right, good afternoon, everybody. I hope you can hear me well and see the slides here as well. So thank you very much for the opportunity. Today I'll be talking about our project that I led with Dr. Hajira Dampamila from University of Southampton. I'm presenting on behalf of the full team in here. As you can see, we had a lot of collaborators from UCL, University of Leicester, and an Office for National Statistics.
Nazul, could I just ask you to put it into presentation mode, please?
All right, sorry about that, thank you. Is it better now?
Yep, that's great, thanks.
All right, thanks. So to some conflicts of interest and funding information, as you know, this was funded by HDR UK and from NIHR. I don't have any particular conflict of interest with this presentation, and but to make sure this is not endorsed by the University of Southampton or BMJ, and that I received some salary from our Office for National Statistics. As a bit of a background, this is from 2018 statistics. We knew that more than a quarter of people in England were living with 2 or more long-term conditions, and we call it MLTC for today's presentation. This is also known that people with MLTC are at high risk of hospitalization and mortality. Particularly during the winter, this was a rapid call with the focus on winter pressure, So we particularly focused on the winter admissions and mortality. While we know that people with MLTC are at higher risk, but which combinations of these diseases make them more likely to be hospitalized is unknown. And the reason for that is a dimensionality of the data. There are 59 multiple long-term conditions that were listed recently in a project led by my co-PI, Hajira. And obviously, we know if we just even take 35 conditions, which were listed as sort of a minimum requirement to consider, it becomes about 34 billion possible combinations. So with the whole population of English data, which is more than 50 million, it becomes increasingly expensive, and it requires very intelligent and clever coding and data management system as well. Fortunately, we had BHF, we focused on that data set. So what we focused on is data minimizing the data and identifying some of the combinations of MLTC that put people at risk. We also did examine intersectional inequality by age, sex, race, ethnicity, and socioeconomic status. We did some analysis to see the modifying or mediating effect, really, of immunization against COVID-19 and seasonal influenza. So these are the three objectives that we talked about. Now, particularly for the winter hospitalization and death, we defined it as the time period between the 1st of December 2021 and the 30th of March 2022. That's the time period that we had the data for the whole period, not for 2023. And as we say, the primary care data set was GDPPR, which was designed for the pandemic preparedness. It was linked with HES, APCs, and several other data sets, as you can see from here, including vaccination data. And to be eligible for this study, people had to be alive on the 1st of December 2021 and age 18 years or above. So we started with 59 conditions, defined both based on SNOMED and ICD-10 codes from primary and secondary care data set. But after discussing with our PPI representatives and clinicians, we ended up using 19, that is combination of actually 23 different conditions for to minimize computational resources. And our approach was to minimize the data to identify some of the combinations of MLTC with the top or the most highest rate of hospitalization. We used over-dispersed Poisson model to estimate incidence rate and incidence rate ratios. From the GDPPR, we had about 50 million people, over 50 million people who were 18 years above, or older and alive on the 1st of December 2021. We had very minimal missing data, about 3.7%, so we didn't do any multiple imputations. We used complete data set for data for our analysis. And we had about more than 48 million people. And in terms of basic characteristics, obviously, it's quite expected that people with 2 or more MLTCs were older and with quite a higher proportion of females. Ethnicity-wise, white, it was overrepresented by white ethnic group, but in terms of IMD, it was reasonably well sort of comparably distributed in these 3 groups. As you can see from here, these are the incidence rate ratios compared to those who had no long-term conditions. So you can see for certain conditions, the hospitalization rate was 17 times higher than people with no long-term conditions. Here, just for the sake of a sort of brevity, we picked top 10 conditions in here. We look into these different combinations. For certain combinations, the hospitalization rate was 1,643 per 1,000 person years of follow-up time, and you have to multiply it 3 basically to understand basically what happened within those 4 months. In the top 10 conditions, cardiovascular disease sort of appeared in almost all of them, and some of the cancer. CKD is for chronic kidney disease. CVD is cardiovascular disease, which had heart failure, hypertension, and CHD together, and diabetes. So the top was cancer, CKD, CVD, and diabetes, followed by cancer, CKD, CVD, and osteoarthritis. I'm not going to the details for all of these combinations, but as you can see, CVD and CKD appear quite often in most of the top 10 conditions in here. We wanted to see if these rate ratios sort of differed by between sexes, female and male. You can see for many conditions, male actually did have high incidence rate ratios, but for not all of those, because sometimes the confidence intervals were slightly overlapping, particularly for CKD, CVD, diabetes, and osteoarthritis. And for these analyses, at least each strata had to have at least 30 outcomes to be eligible for analysis. This is the stratified analysis by ethnicity. As you can see, there are quite a bit of mixed evidence from here. Cancer, CKD, CVD, and diabetes. Sometimes, most of the time, white ethnic group, the incidence rate ratio for white ethnic group was significantly smaller than other ethnic groups. Black, for certain conditions, people from Black ethnic minority had significantly higher hospitalization rate than white, but it was not consistent across all the conditions. That's the heterogeneity that we need to consider. In terms of IMD, because we used over-dispersed model, so the confidence interval is larger, but there was not, after adjusting for age, sex, and ethnicity, there was not much of a difference between the most deprived and least deprived quintiles of IMD. Just for the sake of completeness, all of these analyses adjusted for the other three variables in the model. In terms of deaths, as you can see, just for the sake of reference, people with no MLTC had just slightly below 1 per 1,000 person-year follow-up time. In contrast, people with cancer, CKD, CVD, and dementia had the hospitalized death rate was 345. So as you can see, the mortality was about more than 400 times in these groups, and the top 10, the minimum was 118. That means the rate of death was more than 100 times for each of these top 10 groups. Now, interestingly enough, this here, the most frequent one was chronic kidney disease, and the most fatal combination was CVD and dementia, as you can see from here. And this is so interesting that in that all top 5 combinations, CVD appeared in all of them. However, and dementia. It is also interesting to note that just the 2 disease combination of CVD and dementia had much higher rate of mortality than even some 3, 4, or 5 disease combinations. That was striking. These 2 appeared to be more a fatal combination, really. And as sort of expected, and similar to hospitalization, the incidence rate ratio for mortality was higher for male than female, but this was not consistent. Sometimes the confidence intervals and the point estimates of each other were overlapping between male and female. Similar pattern here as well. So the mortality incidence rate ratio was lower for white ethnic groups but it was significantly higher in Black and South Asian groups, but that was not consistent again. For certain conditions, the confidence intervals were overlapping, so not big of a difference. However, the confidence intervals are quite large in certain cases as well. In terms of IMD, very similar, as you have seen for hospitalization. There wasn't really more independent association between the IMD and these and mortality after taking care of the differences in age, sex, and ethnicity. So to summarize, there are quite a lot to do here. We did some mediation analysis. We have seen about 4 to 8% of the excess risk was mediated through vaccination against either COVID-19 or influenza. But for the sake of time, we did not really include a lot of details from that analysis. But to summarize here, risk of winter hospitalization and death did vary quite considerably between different combinations of multiple long-term conditions. And hospitalization, the highest risk was for the combination of cancer, CKD, CVD, and diabetes, while for death, it was cancer, CKD, CVD, and dementia. Obviously, the different combinations, the risk for different combinations were not exactly identical across different socio-demographic strata. We did some analysis by age as well. Apparently, for above 65 years, it was cancer, CKD, CVD, and dementia as expected. However, quite surprising is that diabetes mellitus came in for people below 65 years of age. We are now examining in more details in terms of incidence of these diseases in the younger population at the moment. So that's all we had to say for today, and I will welcome questions from the audience. Thank you very much for the opportunity.
Many thanks, Nazrul. So that's our two presentations for today. We have some questions that are in the chat, and we've got a few minutes now that we can raise some of them. So the first one in the order that they are now is from Jackie MacArthur. This is Sahong Han and Jinga. Do the rare diseases with increased risk make sense with what we know about COVID etiology, biological pathways? That's for you, Hong Han and Jinga.
Yeah, so sorry. I'm trying to find the question. Can you just repeat again? I think I missed.
Do the rare diseases with increased risk make sense with what we know about COVID etiology and biological pathways?
Well, a short answer, I would say yes, but I'm not expert in this. So what we did is using data-driven approach to identify, whether a rare disease patient or which rare disease patient actually have this higher risk in terms of why and clinical, mechanism level stuff. To be honest, we haven't done that analysis, and as a computer scientist, I could not say too much about that.
Okay, thanks for your honesty.
Yeah.
We'll move on to the next question then, which is from Angela Wood, who says, I also wondered how these results can translate to future pandemics and winter pressures. If these data and results were available earlier, how could they impact public health policies? Yeah,
I think certainly we hope this can be translated into future pandemic or other diseases like influenza. At least the code pipelines we produced, like those, identify those high risk, not just our work, but previous work by the consortium, I think, make things much easier to run this kind of analysis much more efficiently. Even within weeks, we can get this result very quickly. And what we did in this project a bit more compared to other work people are doing, like phenotyping, is we're using machine learning, using phenotypes as a feature set to identify those not coded patients which share similar vulnerabilities like those coded patients. I believe this is a very valuable tool as well. Of course, we have to make sure this machine learning model actually works as we expect. That's why we set a very high bar in our current pipeline, like 80% more confident the model say this patient looks like very similar to those coded patients. The second point is about, what's the second point? Sorry.
It was whether the data results were available earlier.
If the data were available, of course, I think immediate thing we could have done is to include those high-risk patients in our sharing list or in our priority list for vaccination or boosting programs. Now we'll protect those patients, much more efficiently or in a better management planning as a public health policy. Yeah.
Thanks, Han. I'm going to now put a question to Nazrul from Joanna Davis, who says, could there be mortality bias in your data, possibly masking some associations with deprivation, gender, and ethnicity?
Thank you. I didn't quite understand what mortality bias in our data is. Is it trying to say, for example, when we're talking about the association between a particular combinations of MLTC and mortality, could it be sort of mediated or moderated, modified by some other characteristics or confounded by that? If that is something, then I could definitely answer that question. Is it possible?
Joanna, would you like to explain your question, please?
Yeah, I can do. Can you hear me okay?
Yeah, loud and clear.
Yeah, I might have missed in the information that you gave about how you defined your sample, but I was just wondering whether, particularly for deprivation, the fact that you don't see very strong association between deprivation and the number of comorbidities, whether that could be because a large chunk of the more deprived people have died before they've made it into your sample, if that makes sense.
Great question, thank you. Yes, this is absolutely possible because we are looking, particularly because we're looking between a particular time period of winter of 2021 to March of 2022. So it is possible unless we look into the full trajectory of the pandemic. So this analysis should be sort of interpreted as follows. It should be for people who were alive until the end, at least on the day of study startup, so 1st of December 2021. So this doesn't apply to people who have already died. And so you are correct, it is possible. So for that, we need to see the whole trajectory of COVID-19. I agree with you.
Thanks, Nazrul. I think we've got time for one more. And there was some chat between Chris, David, and Honghan. So Chris, I wonder if you'd like to come off mute and put your question directly to Honghan for us. Oh, we can't hear you, Chris.
Is that any better now?
Perfect.
Great. Sorry. Thanks all for interesting talks. Essentially, I was just wondering if this work makes a compelling case for getting the complete set of GP data in the TRE rather than the subset that we currently have in GDPR. I think it was around 2,000 diseases in the diagram that were excluded because they weren't present in the data. And then I think some points or suggestions from David that maybe a cohort like Open Safely might be able to sort of answer whether that data is coded and we just don't have it, or whether the coding hasn't taken place.
Yeah, I think, of course, we need better coded data. GP, particularly SNOMED code is very good in terms their granularity, identify patients. I cannot say for sure whether it's not coded, it's not in the data set, or it's not actually used by a health system yet. Because by the material provided by orphanet, which is the, as I mentioned, community effort for these rare diseases, when they try and create these mappings from the orphanet code to SNOMED code, they create a bunch of new SNOMED code. And this effort happened is quite recently, I think in the last 2 years, something like that. So I would suggest, I would imagine, before 2 years ago, this code is not there yet. It's not used in the health system. And how quick the health system to use this code is another issue. So I might just guess, it's kind of combination of these two, I would say. Yeah.
Interesting. Thank you.
That's all we have time for today, I'm afraid. Apologies that we haven't got through as many questions as we would have liked, but I'd like to say thanks once again to Honghan, Jinger, and also Nazrul for presenting today, and to all of you for attending. And just to let you know that the next webinar will be held on the 17th of May, and registration details will follow in due course. Thank you very much.
Thanks. Bye.
Bye. Take care.